It's my pleasure to introduce Dr. TRACY VANNORSDALL. She's a board-certified clinical neuropsychologist and associate professor within the Department of Psychiatry and Behavioral Scientists in the Department of Neurology at the Johns Hopkins University School of Medicine. Dr. VANNORSDALL's research focuses on developing methods to improve cognitive functioning in those at risk for neuropsychological declines due to illness and medical treatments. She's a member of the Johns Hopkins post-acute COVID-19 team, which is one of the earliest dedicated multidisciplinary COVID-19 survivorship clinics in the nation that's working to understand the neuropsychological sequelae, clinical course, and treatment needs associated with COVID-19 infection. So please join me in welcoming VANNORSDALL.
Thank you so much for having me. Get us started here. And there we go. So thank you so much for the wonderful introduction. I'm going to be speaking to us, starting off talking about PASC, or post-acute sequela of COVID-19, otherwise known as long COVID. The WHO, the World Health Organization, defines this as a lack of one's return to the usual state of health following a COVID-19 illness. And it can include the onset of new or recurrent symptoms that occur after that acute illness has resolved. And these persistent symptoms last 4 or more weeks after infection with SARS-CoV-2. And when we factor in new infections in unvaccinated people, we can conservatively expect more than 15 million cases of long COVID resulting from this pandemic. So we need to be ready for that. And these persistent symptoms can affect multiple bodily systems, including the central nervous system. We don't know exactly how long these symptoms will last or what proportion of individuals is likely to be affected. But we do have data out of countries, particularly that first experienced the first big wave of the pandemic and have had time to study these issues and start to shed light on what we can expect. So data from a 6-month follow-up study of hospitalized patients found that at 6 months, 3/4 of patients were experiencing at least one or more physical or mental health symptom. When we think of COVID, we think of pulmonary disease. And so at 6 months out, about 1/4 of patients are reporting dyspnea or continued difficulty with their breathing. But we're also seeing that 23% are reporting clinically relevant symptoms of anxiety and depression. And if we take that out just a bit longer to 1-year follow-up, and in this study, it's a large study where most of the patients were hospitalized, but not in the ICU. So they were somewhat less ill than in some of the populations that we often read about. Here at 12 months out, around half of patients are still experiencing a physical or mental health symptom. And again, we're seeing nearly equivalent rates of pulmonary symptoms with mental health symptoms like anxiety and depression. And compared with matched controls, a greater proportion of patients who have COVID will be experiencing things like pain, anxiety, or depression 1 year out. So how is COVID affecting mental health? What is the mechanism? Very briefly, there appear to be 3 potential biologic pathways. One is respiratory and systemic disease, where we have this hyperinflation, a hypercoagulative state of the blood vessels, which can lead to stroke. We're also thinking about direct invasion from the central nervous system and post-infectious immune-mediated complications like Guillain-Barré. The critical illness literature has really proved critical for our understanding of what we might expect in our COVID patients from a neuropsychological or neuropsychiatric perspective. As everyone's aware, COVID-19 is resulting in a significant spike in the number of people who do require care in the ICU. And many of these folks will experience acute respiratory distress syndrome or require mechanical ventilation. And we know that in up to 80% of those survivors, they experience new or worsening physical, cognitive, or mental health impairments that persist beyond hospital discharge. And these are collectively known as the post-intensive care syndrome, or PICS. And survivorship after ICU is very similar to survivorship issues after other conditions. We see a lot of physical disability due to the mechanical ventilation and sedation. We also see high rates of cognitive difficulties. And by that, we're talking about things like attention, your ability to remember things, your ability to plan and organize. And that tends to be particularly poor in our survivors if they've experienced a delirium during the course of their hospitalization. And then we also know that our survivors of acute respiratory distress and PICS tend to experience clinically significant anxiety, depression, and PTSD that occur in about 1/4 to 1/3 of survivors and can persist up to 5 years, right? And then there are additional issues of stigma and fear, where we know from the earlier SARS epidemic, for example, that constant media coverage that emphasize high death rates, stigma about spreading the disease to others, fear that you've infected a loved one, and things, feelings like guilt for surviving or for having infected those in your house can really all contribute to mental health difficulties for our patients. And this is a challenging area to study for a number of reasons. First, there's marked variability in the types of symptoms that patients present with. The trajectory of those symptoms over time varies from person to person. This is all happening against the backdrop of elevated pandemic-related stress, social isolation. It's also the case that we're likely unmasking or exacerbating previously undetected cognitive or psychiatric issues. And we're also trying to tease apart what is the effect of the virus versus the effect of the treatment, things like mechanical ventilation that we know are bad for our thinking skills. But we do have reason to believe that patients experience a worsening of their mental health and cognitive functioning in relation to their COVID illness. So when compared to 6 other conditions like the flu, upper respiratory infections, or fractures, COVID-19 is associated with more first diagnoses of psychiatric disorders within 90 days compared with all 6 of these other health events. And so that's shown here in the red lines along the top of each panel. And we tend to see higher rates of anxiety as well as depression and insomnia. Additionally, it's also the case that having a new diagnosis or a relapse of a pre-existing psychiatric illness is significantly higher following COVID-19 rather than those other, relative to those other conditions. And we see this even in patients who did not require a hospitalization. So it is not simply the sickest of sick that are having these elevated rates of psychiatric illness and distress. From a cognitive perspective, the data are emerging that are starting to characterize patient outcomes. One recent review article on objective, meaning tested cognitive performance across 12 studies, concluded that patients with a recent infection tend to have poor global cognitive difficulties or global cognitive performance, impairments in their ability to remember things, to pay attention, to engage in more complex reasoning tasks, and in particular, verbal fluency tends to be negatively affected. So in light of these issues, how do we care for patients following a COVID-19 illness? Well, given the physical, cognitive, and mental health symptoms that they experience, it really suggests a need for a coordinated, multidisciplinary care approach whenever possible. And so I'm going to share the approach that we've taken at Hopkins and some of our outcome data. So our post-acute or PACT clinic was started in April of 2020, so fairly early in the pandemic, by Dr. Ann Parker, and the program is now co-led by Dr. Alba Azola. And they used a PICS framework for a multidisciplinary service that really relies on our pulmonary and critical care medicine teams, physical medicine and rehab, and our home rehab services. This was initially telemedicine. It's now a hybrid model, and it's very much multidisciplinary. There are partnerships with psychology, social work, psychiatry, and many other types of providers. And we see folks who are treated in the ICU, as well as individuals who were able to convalesce at home. So really a range of acute illness severity. We've seen, hundreds of patients so far. They tend to be, on average, in their middle age, and they're racially and ethnically diverse, just like the Baltimore region. And so around the time of a patient's first follow-up PACT clinic visit, so about 4 months after their illness, they undergo a cognitive testing battery and questionnaires that are administered over the phone. And so we're looking here at outcomes. I'll show you in patients who varied in terms of how sick they were. 34 patients were hospitalized, but did not require an ICU stay, or perhaps didn't even need to be in the hospital. They may have convalesced at home, whereas the other 48 patients were treated in the ICU. And so our patients on average were, in their 50s, a few more females than males, and they were bright and a well-educated group. And so we're testing them in terms of their learning, their memory, their thinking speed, their executive functioning, their attention, their ability to manipulate information in their mind effectively, and in their speed and language skills. And we're defining impairment as mild or moderate if patients are performing below the 7th percentile relative to their age, and severe if they're below the 2nd percentile for their age. We're also asking about their mood symptoms, anxiety, trauma-related distress, and their functioning in relation to their cognition and their mood. And what we see here is that patients treated in the ICU, as well as those who are not in the ICU, they tended to perform below expectation on most tests, particularly tests of fluency, processing speed, new learning, and memory. And we see in the dark blue lines that the scores do tend to be lower for our patients who required more intensive treatment in the ICU. Another way of showing these data demonstrates that 67% of our PACT patients produced at least one impaired cognitive score across these 8 domains. And we didn't see differences in the rates of cognitive impairment by clinic. So it didn't tend to map on to how sick patients were acutely. Additionally, more than 1/3 of our patients are reporting moderate or clinically significant elevations on one or more measures of psychiatric functioning or daily functioning. Our scores on these measures did not differ based on whether they required an ICU stay or not, and they were unrelated to their cognitive performances. So just because you may recover well from a cognitive standpoint does not necessarily mean that a patient would recover well from a mental health standpoint as well. And it's also important to look at those rates of functional decline and appreciate that these are declines in functioning related to specifically to having trouble with memory, thinking skills, or with your mood. So these data suggest that at 4 months after diagnosis, across a diverse patient population with respect to both demographic and illness characteristics, ongoing cognitive weaknesses, emotional distress, and related functional decline is common. And it really highlights the need for multidisciplinary care teams. Our structure allows us to detect and intervene and address these persistent cognitive and neuropsychiatric symptoms. So after a patient goes through the phone screening, we are meeting as a team every week and triaging our patients to the correct provider: neuropsychology, rehabilitation psychologists, psychiatrists within the Hopkins system or in the patient's home environment. There's very little research that's been done so far on specific mental health treatments post-COVID, but we are effectively able to rely on interventions with demonstrated efficacy derived from other patient groups. So moving forward, we need more research that carefully follows our patients to determine the trajectory of these issues, the predictors of persistent neuropsychiatric symptoms, more carefully defining the care needs of patients and their families, and determining the most effective mental health and cognitive treatments and figuring out when we need to administer them and to whom. So I want to thank everyone for your attention.
Thank you so much for sharing those excellent comments and this really wonderful approach to being able to address the long-term sequelae of COVID. It certainly strikes me that we are fortunate at Hopkins to have so many resources to be able to bring such a comprehensive approach. And, you know, obviously mental health resources in so many countries is so under-resourced that this, you know, presents a real challenge. And I see we have several questions for you in the chat box. I will comment on one that I saw. Was that, are we going to expect with the mutations now with COVID that the sequelae may look different? Or is your clinic tracking that?
I think that's a wonderful question. I think that we're not tracking it in the moment in terms of whether someone has an Omicron variant or a Delta variant, but I think that logic would tell us is that if more patients aren't ending up in the hospital and are not ending up in the ICU, that we should have a milder course. I think it still remains to be seen whether the rates of persistent symptoms is less in our Omicron variant patients relative to earlier patients with earlier variants. But I think once patients end up in the ICU, those factors, mechanistic factors, come into play, and I think we'll still be expected to see significant cognitive and mental health morbidity associated with their illness.
Thank you so much. Any, one more question? Have time, one more quick question?
Yes, and I have a question here. And the question is the following. Are there ways that people can self-help themselves after being sick to improve their mental capacities? What practically can people do, once again, to help themselves, by themselves?
Yes. So I think that taking care of one's health, resting, making sure that you're getting a good diet, nutrition, sticking to a routine, sort of the behavioral rhythms of life, and giving yourself some grace. Take notes when you need it, give yourself extra time to complete projects. I think generally speaking, at least around the folks I'm around, we're very aware of sort of the COVID brain fog and that notion. And I think, you can share with those that you feel comfortable with that you're not quite back at your best mentally or cognitively, and ask them to treat you with some grace for a while as you work on building yourself back up. But it's generally, self-care and reducing expectations for a bit as you recover, and appreciating that this will be a trajectory, and also, reaching out for help with professionals if you find that you're continuing to struggle.
Great. Well, thank you so very much.